everyone, so we can get started. I know that people will be coming on as we go. So we just want to welcome you to our second HQIC informational webinar for Michigan, Minnesota, and Wisconsin hospitals. A few housekeeping announcements before we get started. We ask that during the presentation that you please mute both your phone and computer audio due to additional noise feedback that may occur. We will have time after the presentation for Q&A in which you may unmute your lines. If you have any questions during the presentation, feel free to use the chat box found at the bottom of your screen. With that said, it is my pleasure to hand it over to Michelle Norcross, our HQIC director, who will be giving today's presentation.
Thanks so much, Naomi, and thank you everybody for joining us today. I'm really excited to share with you about the Hospital Quality Improvement Contract, or the HQIC. As you know, we have historically worked under the HIN in our 3 states, so again, Michigan, Minnesota, and Wisconsin, and we're really excited to be working, Superior Health be working with the group called IPRO, who is a national QIO. So we wanted to share with you today some more information about the HQIC efforts, how you're going to be able to participate, what the work is that we're going to be doing, as well as focusing on some metrics today. So we're really excited to cover this with you. So the IPRO HQIC is really leveraging innovation across geographic regions to support hospitals in reducing all-cause harm. As you know, this is the second, an additional iteration, I should say, of the HIN work, and so we're really excited to be continuing these efforts. We're going to be able to bring together expertise and resources, including leading quality improvement organizations, established hospital associations, and national experts in person and family engagement as well. So this is the IPRO HQIC organization target area. As you can see that we are working in 15 states as well as DC. And so these are the contractors that are really engaging in this effort. IPRO obviously is the prime contractor. They are based out of New York. We're also working with Health-Centric Advisors, the Kentucky Hospital Association, Clarent, Q3 Health Innovation Partners, which includes Ohio, Pennsylvania, as well as New Jersey. And then we're also working with a group called AIR, which is the American Institutes for Research. This group may sound familiar to many of you on the call because they were historically the patient and person and family engagement contractor under the HIN historically for CMS. And so we are really thrilled to have a national organization that has led the entire nation in person and family engagement be working directly with us on this. You may also be familiar with the name Clarent. Clarent was the national content developer under the historical HIN contract for CMS as well. And so we're really excited to have this major expertise being brought to us across our states and region. So the IPRO HQIC approach is really for you to engage with us at your own pace. We have a 6-month enrollment period, which is going to be ending in early to mid-March. And during this time, there's going to be some optional activities of which enrolled hospitals will be able to participate. You'll be able to engage with peer-to-peer networking through the online community. You will be having access to one-on-one technical assistance on any of the 8 core areas of harm or on COVID. We will be recommending a person and family advisory council. And so if you can provide us with a name of an advisor to participate on our IPRO HQIC-wide PFAC, we would be thrilled to have you participate in that. And also providing input on new tools and resources in development in an area of interest. So again, we want this to be meaningful to you. So any input that you can provide to us in topic areas that are of particular interest, we will be more than happy to try to assist you in those endeavors. So what can we offer you? We can offer you technical support at no cost, which includes data analytics and benchmarking, data dashboards to engage your board, PFAC, and staff in quality improvement. We're going to be able to offer the ARC Culture of Safety Survey, opportunities to participate in patient safety learning collaboratives, gain access to resources, be able to share with your peers, as well as have metric coaching. Both in person and family engagement, but in general as well. They are using Tableau, and I will say I have been very impressed with the dashboards that have been developed thus far. There's also a plethora of subject matter experts that are going to be at your disposal, from clinical patient safety, quality and performance improvement, data analytics and claims data access, rural and critical access hospitals, ECHO, PFE, AIR, which is again that national contractor historically, so we're really thrilled to have them, as well as health equity experts and high reliability. So we want to meet you where you are, and we're again going to be working to reduce all-cause harm. So these are the topic areas. If you participated in HIN in the past, you're going to see that these are very familiar as they were historically under the HIN. So we're focusing on opioid stewardship and behavioral health, adverse drug events, CAUTI, CLABSI, C. diff, MRSA, and antibiotic stewardship, sepsis and septic shock, pressure ulcers and injuries, as well as readmissions and care transitions. So talking about the goal, just as a reminder, under this contract, CMS has 5 large aims that have been focused for this IPRO contract, which is a larger overarching contract for all areas of harm in all settings. And so they have 5 specific goals that they've been focusing on. For the HQIC contract, we're going to be focusing on 3. So the first goal is focused on behavioral health outcomes, and it's decreasing opioid-related adverse events by 7%, including deaths with a focus on Medicare population. Our measure specifically is going to be prescription opioid-related overdose deaths per 100,000, and we are going to be pulling that from the CDC directly. For the second goal, we're working on decreasing opioid prescribing in hospitals by 12%. We're going to pull that from Medicare claims information. So this is going to be Part A and D claims, and the measure specifically is going to be the percent of opioid naive patients who are discharged with an opioid. The goal 1.1.2 is going to be focusing on decreasing opioid adverse events, including deaths, by 7%. That again is also going to be pulled from Medicare claims, and that is going to be specifically opioid-related adverse drug events per 1,000 persons. For the second overarching goal, this is increasing patient safety, and that is the goal that CMS has charged us with. So we will be reducing all-cause patient harm in recruited hospitals by 9%, and we are working to develop a composite score that will apply standard ordinal scale to each measure to compute overall score. So we're going to be working on looking at opioid stewardship, including increasing the percent of patients prescribed naloxone who have an active opioid prescription on the day of the hospital encounter and an opioid claim within 7 days of discharge. And again, we're going to be pulling that from Part A Medicare claims. For the next piece, we're going to look at ADEs related to opioids, including those specific adverse drug events related to opioids per 1,000 persons, which is again going to be pulled from Medicare claims. ADE anticoagulation, which is going to be related to 1,000 persons, again, from both Part A and D of Medicare claims, and then adverse drug events related to glycemic. And so that is, again, going to be among Medicare beneficiaries discharged from a recruited hospital from both Part A and D claims as well. So you're going to see a theme here that we are really working to pull metrics that are low in burden to our hospitals. So you can see that we're pulling historical information from CDC. We're also pulling a lot of Medicare claims as well. The other source that we're going to be pulling from is NHSN. And so you're going to see that as we continue some of this infection-based information, that we are going to be capturing that through the NHSN database, which many of you are already entering in directly as well. So for CLABSI, we're going to be pulling the SIR related to CLABSI, for ICU, including NICU. We're also going to be pulling the SIR for CLABSI for ICU and other units, and then the CLABSI utilization ratio. Additionally, we're going to be looking at CAUTI. So we're looking at the SIR for ICU as well as ICU as others, as well as CAUTI utilization. We're going to be pulling the SIR for CDI, which again is focused on ICUs and including NICUs. We're going to be looking at sepsis, which is post-operative sepsis cases, which again is going to be pulled from Part A claim information. pressure ulcers, which is going to include stage 3 or 4 pressure ulcers or unstageable. And that's again going to be pulled from Part A claims. And then readmissions, which is going to be focused on all-cause hospital 30-day readmissions per 1,000 Medicare beneficiaries, which is again pulled from Part 8 claims. For the next focus of the goal, we're going to be reducing ADEs in recruited hospitals by 13%. And so this is not including our opioid metrics, which were already discussed, but we are going to be focusing on anticoagulation related ADEs, which are going to be pulled from Part A and D claims, as well as glycemic related ADEs from Part A and D claims as well. And then we switched to goal 4 because, as I said, CMS has 5 big goals across all of the setting areas, and we only have 3 focus. But to prevent confusion, if you're participating in multiple, they kept the goals the same. So we are focusing on goals 1, 2, and 4. And so the 4th goal is reducing readmissions by 5% in recruited hospitals. And this is going to be all-cause hospital 30-day readmissions, again, being pulled from Part A claims. So as you can see, all of those metrics that we covered are going to be coming from some type of source that already exists in the majority of your hospitals. So we're trying to pull data from you that is going to be low burden on your hospital's part. These are the only 5 metrics at this point in time that we expect that you will have to manually enter on a regular basis. And so for our person and family engagement, again, this is going to be led by AIR, who are subject matter experts in this area. We are going to support you in implementing the best practices, and we are going to be focusing on these 5 areas to drive improvement in person and family engagement over the next 4 years. We're going to be implementing a planning checklist for planned admissions, implementing a discharge planning checklist, conducting shift change huddles and bedside reporting with patients and families, designating an accountable and responsible hospital PFE leader, and activating committees in which patients are represented. So one thing to call out here is that rural hospitals and CAUSE with no planned admissions are not expected to implement PFE metric 1, and we will find that information out from you and make sure that you do not have to track that information. These would be manually entered into a database that we are working on developing. IPRO will be the source for you to be able to enter that information in. Then we're also going to be focusing on health equity. So programmatically structuring health equity to be baked into our analytic stratification, technical assistance, as well as learnings. And so we really want health equity to be at the core of the work that we're doing. We want to provide opportunities to share COVID best practices with a health equity lens. And we also want to support in identifying, implementing, and measuring the effectiveness of new strategies and solutions to make sure that we're collecting real data. Make sure that we're identifying healthcare disparities in the HQIC patient safety focus areas, closing disparate gaps in care or outcomes, as well as engaging persons and families in all aspects of health disparities reduction work. So this is the team that is going to be working on HQIC from the superior health lens. So you have myself, who's the HQIC director. You have Christy Schaefer, who is the QIA out of Michigan. You have Jenny Schonecker and Janelle Shearer out of Minnesota, and then you have Jill out of Wisconsin. This is a phenomenal team. I have been absolutely thrilled to be working with each and every one of them. They have a plethora of experience for you, and I really love that you're going to be able to have direct access to each of these QIAs to really help you on your journey. I wanted to make sure that we have time today to answer any questions that you might have, because I know that we've been in communications with you. I know that you're engaging with us as you make your decisions if you want to participate with HQIC. And I'd love to take any opportunities to answer any questions that you might have today, and see what we can do to have you engage with us in this work.
Michelle, at the moment, we have no questions in the chat box. If you have any questions, please unmute your lines.
So I do know that we have received a couple questions from from colleagues via email, and so I'd be happy to answer a couple of those at the moment as well. One of which is around eligibility for some of these data metrics. And so I understand that not all of the hospitals on the line may care for patient populations that meet some of these data requirements. And if that is the case, we will be contacting you once you're enrolled to understand what patients you are caring for. I think one of the prime examples is around CLABSIs. So if you are not caring for central line patients, that certainly would be something that we would find out from you, and then we would make sure that you are not responsible to enter any of that data, or we would not pull that data from you. So there's another question about if there's any cost associated to participate. No, there is absolutely no cost for you to participate. This is a free initiative for you to engage in, and I think it's really whatever you put in, you're going to be able to get out of this. So you will have access to the subject matter experts. You will have access to a plethora of resources, several of which we covered during this call. And I can certainly kind of go back and share some of those with you again. But these are some of the pieces that you will have access to minimally through the participation. You're also going to have designated access to your quality improvement advisor. So if you need assistance in any of these topic areas, we are here for you. So there is absolutely no cost to participate. Great question.
So this is Marilyn from Community Memorial Hospital in Cloquet. And I know I filled out my submission forms and all that, but when will we know which hospitals and who's going to be involved in this project? Is there a deadline date for that?
So right now, our absolute deadline for participation is March 15th. And so that is the last day absolute for recruitment. Now, if we hit our minimum threshold, which is 125 hospitals in our 3 states, we are not able to recruit anymore. And so we do have, we are trying to recruit as many as possible, as quickly as possible, but it is likely that we would hit that number prior to that deadline. So we would be more than happy, once you're enrolled, we can share the list of hospitals that are engaging. That is allowed. We cannot share if you are not enrolled in the work, but we are more than happy to engage you in that conversation earlier.
Okay, and like I said, I did enroll quite a while back, so
perfect.
You should have all the paperwork. Thank you.
Thank you.
Michelle, we have a question that came through the chat box, and they're asking, what are the requirements of the hospital team if they are participating in this contract?
It's a great question. So our hospitals are really going to, I think the expectations are, number one, be submitting the data. Again, the only manual entry data that is required at this moment is the person and family engagement measures. And so those are the 5 metrics that you would enter on a regular basis. Most hospitals are already entering into NHSN. If you're a critical access hospital and you're not entering into NHSN, we are working on a solution for that, for you to be able to capture that in a different way. So making sure that you're submitting your data is the number 1 requirement. The other pieces are really, what is going to be most important and meaningful to you and your organization. We are going to be offering technical support. We are going to be offering learning opportunities and collaboratives. We're going to be engaging you and helping you drive that improvement. But, we want to meet you where you're at. And so if your organization, needs to focus on COVID right now, that's absolutely fine. We want you to focus on that. And if you need assistance in that, we can help you. If your organization really is prioritizing opioids and needs assistance in that, we will assist you in that as well. So those topic areas that we really were covering earlier in these slides, in terms of these 8 topic areas, this is really the bread and butter for HQIC. And so whatever support you need in these topics, we will be able to assist you in. And it's really about, whatever you want to put in, I think you will get out. So if you need assistance from a subject matter expert, we can supply you with that. If you want to talk to a peer who's engaging, and again, we're going to be working with 275 hospitals across these 15 states and DC. And so there's a great opportunity for you to be able to learn from your colleagues as well. And so we're going to be asking you to participate in work, but it's totally up to your organization how involved you would like to be.
Another question that came through was just on how to get a copy of the slides that were sent out.
We'd be more than happy to email you a set of the slides. So we will make sure that we have everybody's contact information and would be more than happy to provide these slides for you after this call. And we also have a set of just the measures if you're interested in just the measure slides as well. We certainly have those if you're interested in those, or you can have the entire slide deck. It's certainly your choice. And we can send both, absolutely. Thank you. Are there any other questions? These are all fantastic questions.
I am not seeing any more through the chat box.
Okay, thank you. I'm going to put our emails up one last time because I know that, sometimes questions arise after these presentations, and I just wanted to spend that little bit of time today to provide you with that overview of what we're going to be offering over HQIC. We're really excited about this opportunity. We think it's going to be a fantastic opportunity for our hospitals to engage in. Again, being able to learn across a much larger geographical area, we're really excited about as well. And we have some wonderful partners that we're engaging with. So please feel free to take a note of any of our email addresses. If you'd like to enroll and you're ready to enroll, I would highly encourage you to go to our website. This is where you can get the enrollment form and just fill it out, and then we will be in contact with some of your next steps. But I thank you so much for joining us today. Again, if you have any additional questions at any point in time, I highly encourage you to reach out to us. We're available to you, and we are hoping to be able to work with you in the near future. So thank you so much for joining today.